So I had this patient, right? And she was having some shoulder pain. At the same time, she was limited in her shoulder abduction. What should have been this was only to about here. So this is a limited range of motion. It's one of those things you have to look out for full body integrated movement. If any one part is off, somehow every other part is off. But let's not go too far ahead. In any case, it was only with active range of motion that it was limited. For the most part, with assisted range of motion, or abduction in this case, she could lift her shoulder up pretty high. Not completely, not to a full range, but pretty good. So this means that there is a contrast between the active and passive. And when this is the case, you know that the firing of the muscles, that the nerve supply to the muscles that control that action and the arm, therefore, are at odds. So we have to figure that out. If something won't lift up fully, something must be holding it down. And of course, with shoulder abduction, with actually moving the shoulder fully up, you have to consider that it is not just a shoulder joint, not just a humerus action. It is as well a scapular clavicular action. So these two guys here, that one and that one, also have to lift up. So we have to consider that. So many of the muscles actually have a downward orientation to them. The ones that first come to mind are the lower fibers of the trapezius, for instance, going down about as low as T12. But of course, there are fibers that are a little higher up than that as well, in that lower level. We, of course, can call upon the latissimus dorsi, one of our favorites, and it goes from more of the front of the arm all the way down to at least as low as here. It has a lumbar iliosacral attachment. We're just going to eliminate that for clarity's sake. So you can see we're starting to build the idea of these downward attachments. As well, on the front side, switching views, we have multiple other muscles. We could, of course, talk about the pec minor muscle, which is a coraco process to ribs 3, 4, 5. And then at the same time, we have pec major, which, of course, upper fibers are clavicle, sternum, but its lower fibers are as well going to at least as low as the rib cage in this particular case. So these are all important. Looking at it from the back again, if you're around the front, you would see them attaching like that, pec major, pec minor, in this rough area. So net product is that if these muscles were firing inappropriately, we would get it so that we could take that humerus and jam it downward with all those muscles working together. We get that pull opposing the lifting of the humerus, as well as the clavicle, as well as the scapula. And when this is the case, there is a joint capsule and ligaments, which are really one and the same, around that GH joint, around that glenohumeral or shoulder joint. And so this is quite likely what was being strained when we're talking about that shoulder pain. This is what was being irritated. But of course, there's more to it than that. The strain has to be a product. The muscular pull has to be a product of something else. So when looking at where those muscles attach to on that lower end, we found that the ribs were depressed. This is a general outline of a rib cage, usually. This was more or less what we found. A depressed, not sad, but a depressed or exhaled rib cage. It was favoring exhalation. And when this is the case, when the ribs are relatively low, it means the attachment points sink down with it. So the clavicle, scapula, and the shoulder joint as a whole is give or take right there. And it means that anything that attaches to these things is at a greater distance in this position. Now the interesting thing is, this shoulder pain started to occur after a period of exercise. And it was not the exercise that caused it. This is an important distinction. When the patient first started seeing us, there was quite the significant flexion extension pattern through here. So it means that the ribs were being on an angle, pushed down towards exhalation. That's where they were sitting based on their spinal relationship. But as the back muscles increased in strength, as functional mobility came into play, and the patient started to improve in the spine no longer favored exhalation, but the ribs stayed put. They stayed in this downward position. And this is an important distinction because it means that the exercise did not cause the problem. It did not cause the change in distance between one point to another. It simply exposed the fact that the ribs were not fully capable of moving. And that actually means progress, not regression. And that's an important distinction. But it goes further, of course. We have to look at why those ribs were not inhaling. And so we have to figure out what controls that. It turns out it's an area in the neck. So if we're looking at the neck from the side here, what should be a normal smooth curve was not a normal smooth curve. How could it be? When it was looked at, in that there's, let's see, 1, 2, 3, in that 3 to 5 region, 3 on 4, 4 and 5, we actually had a bit of an anteriorization, as if it was being pushed forward at this point here, quite far forward, palpably far forward, not dangerously, not life-threatening far forward, but enough to cause some strain on the ligamentous structure supporting it, probably some irritation through the nerves that happen to come off this area. And in fact, these are the same nerves that form the phrenic nerve. The phrenic nerve being the one that goes all the way down, powers the lower intercostal muscles, as well as the respiratory diaphragm, your main inhaler muscles of the body. So the fact that these ribs weren't able to fully inhale, to reverse their exhale position, could have been, possibly, could have been from the fact that the neck was not working. And another interesting point is that this overlaps pretty well with the nervous innervation that goes to all of the muscles of the arm, the C5 to T1 area, what we call the brachial plexus, which sends all kinds of different nerves to all of the muscles and controls the tone and general innervation to everything related to this arm, to the neck, to the ribs. So as always, it's complex. If you can, fix it all.